Hello, good afternoon, ma'am.
Good afternoon, ma'am. Am I
Yes,
audible, ma'am?
yes, ma'am. Ma'am, if is it possible for just checking the presentation once?
Yeah, I will share my slide. Is it fine, ma'am?
Yes, yes, it is absolutely fine, ma'am. And if yes, right. Okay, yes, starting. Now you can unshare your slide right now. Rajeshwari, ma'am, we are starting, right?
Yes.
Okay. Good afternoon, one and all. We wish you a very world happy Physiotherapy Day that we just celebrated yesterday all across nation and worldwide. Myself, Dr. Neha Singh Mandade from IAP Digital Media team. I am the host for today's webinar, that is day 7. And for today that we have with us Rajeshwari ma'am and with the topic understanding falls in elderly. Also, let me also tell you and introduce a few about IAP Digital Media team. The IAP Digital Media team consists of Zoom platform, webinar live streaming, and IAP profiles on social media platforms that is Facebook, Instagram, Twitter, LinkedIn, and YouTube. You may follow us and our profiles on these social media to receive notifications for our events such as webinars, workshops, CMEs, conferences, health camps, blood donation drive, and to know more about recent updates on physiotherapy. The Indian Association of Physiotherapists is the oldest and largest association representing physiotherapists in India since
Ma'am, is there any issue?
Hello, ma'am. Am I audible now?
Yes, ma'am, I'm audible, ma'am.
Was everything logged out? Or because my connection, I think, was lost in between?
Yeah, in between.
Yes, just to continue, you may subscribe to our IAP YouTube channel for the notification of our live webinars. In the playlist section of this channel, the webinars are segregated into various folders on the topics like orthopedics, neurology, sports and fitness, pediatrics, cardiopulmonary, women's health, research, cancer rehab, etc. for easy access. And the social media links would be shared in the chat box shortly as we are live streaming on YouTube. I now hand over the further sessions to be continued to our today's moderator. Ma'am, over to you. Thank you. Hello. Mohan Priya, ma'am, are you there with us? Do we have anybody else from the team? I do not see Mohan Priya, ma'am. Mohan Priya, ma'am, are you there to take over? Mohan Priya, ma'am, am I
Yes,
audible
ma'am.
to you?
Yes,
Yes, you may
ma'am, audible.
continue. Yes, thank you.
Good afternoon, everyone. I'm Dr. Mohanapriya, physiotherapist from Chennai West Sub-Coordinator. It's my privilege to introduce our distinguished speaker, Dr. Rajeshwari ma'am, a highly accomplished professional in the field of physiotherapy. She holds a PhD in physiotherapy from Dr. Ramachandra Institute of Higher Education and Research, and brings with her over 25 years of experience in both clinical and academics. At present, she serves as a professor in the Faculty of Physiotherapy at Sri Ramachandra Institute. Dr. Rajeshwari ma'am has made significant academic contribution, having published 22 research papers in reputed journals. Her dedication towards teaching, clinical excellence, and research, especially in neuro and pediatric rehabilitation, is truly inspiring. Today, she will be delivering a talk on the highly relevant topic, Understand Falls in the Elderly. Ma'am, we kindly request you to go ahead with your presentation. Thank you.
Thank you, ma'am. Thanks for the introduction. Am I audible, ma'am?
Yes, ma'am.
At the outset, I would like to thank IAP India, Tamil Nadu IAP Women's Cell for giving me this opportunity to present in this forum. So to go on with my session, today we'll be just seeing about understanding falls in elderly. So the learning objective of this session would be to outline the causes of fall in elderly population, to outline the fall risk assessment, to outline fall preventive measures, and to outline an exercise program and evidence-based intervention. So before going on into the fall, let me look at or let me say about what is the status of elderly in India in terms of the statistics. See, according to the National Statistics Government of India 2021, there are nearly about 138 million elderly persons in India, and which is about 67 million males and 71 million females. So this has found to increase drastically, and you can see in this graph, right? So in 2021, it was 66.8 and 71.1 million. And the expected increase in 2031 is somewhere around 92.9 and 100.9 million in terms of males and females. And probably on one side, we should be very happy. This all because of the technology advancement, the age span of individuals surviving is increasing. But then it is drastically going to increase by 2031. So we need to be equipped, right from the medical professional or a therapist, right? We need to be very much equipped with regards to this expected populatory growth. And coming on to the main topic of this session, fall. So how do we define a fall? A fall is defined as an event that results in a person coming to rest inadvertently on the ground or floor or other lower level. This is as per WHO definition, where a person is going to land up to the ground without any reason or without his will. So that's called as fall. And this is a very common problem associated in elderly individuals. You can see in elderly, falls and fall related injuries are very common, and it's a serious problem for older people. This fall potentially is life-threatening many times because that can result in a traumatic brain injury or any other reasons, right, where a patient is going to have severe fractures, putting him into a bedridden state, and that can result in death also. And sometimes this could be the first sign of a single problem. Say, for example, if it's going to be a Parkinson patient, probably the people in the family did not identify the problem, and probably this fall could make him land up to a hospital where he's being diagnosed to be having a Parkinsonism. So, as I said, this leads to hospitalization, increased cost and burden on society, and even lead to death. So, when you look into this fall, the incidence of falls, 25% of 70-year-old individuals are going to have this fall, and it keeps on increasing as the age keeps on increasing. Somewhere around 35% and 40% are going to have incidence of fall in the age of 75 and 80 years. And it is said that women fall twice as much as men until the age of 75, and where the frequency equalizes later on. Why this so? It was found that in research that women do have a lot of gait abnormalities after the age of 60. That's why the fall incident is going to be high. Apart from that, they do have other issues in terms of bone density, lower bone density, vitamin D problems, and so on. That could be the result of increased fall frequencies in women than in men. And 1/3 of elderly who live at home have at least one fall in a year. The reason for fall could be multifold, right? Probably there could be some underlying medical issue, or probably it is because of a simple slip. And so whatever it could be, it is found that 1/3 of elderly have at least one fall in a year. And fall and its sequelae are the 5th most common cause of death among aged, right? So probably, as I said, it could be because of fracture or a traumatic brain injury and so on, which is putting the patient into a bedridden state, and many times the secondary complications could be the reason for their death. So falls, as I said, the leading cause of injury and death according to the National Council of Aging due to fractures, reduced mobility, or loss of independence. Many falls are preventable through awareness and proactive measures, right? So that is what we are going to look into the entire session today. How to identify, how to prevent, and how to treat a person who's going to be having a fall. Before going on to the assessment, let us look in for what could be the intrinsic and extrinsic factors that could result in fall. The intrinsic factors are those related to the aging process. So there could be changes in the mobility, balance, and reflex. Again, when you see what could be the reasons for reduced mobility or balance, probably it could be because of decrease in the muscle mass, or there could be a decreased sensory component, right? So there are a lot of studies saying that the touch receptors present in the skin are going to be having a lot of degenerative changes, and that can result in decrease in their balance, because the sensory component plays a very important role in balance, and that could be resulting in decrease in the balance. And sarcopenia, what is sarcopenia? Reduction in the muscle mass and thereby resulting in reduced functional performance, right? So that could be a very important intrinsic factor. Frailty. Frailty is nothing but a person with frailty will not have much of specific disease, probably the age-related problems, which is put down or brought him down into his functional performance, putting into a reduced mobility or sometimes even to a bedridden stage. Probably if you address the geriatric problems in terms of age-related, the patient or the geriatric person can really come up with a good quality of life. Cognitive issues, delirium, and dementia. See, sometimes you can see patients, especially who's got Alzheimer's or dementia, probably their movement would not be a problem. They would not have any problems with any movement, but still the cognitive issues, they don't know what to do next, right? Probably that could be the reason for their falls. Vision and hearing loss, I need not say how a vision and hearing is going to contribute for a normal movement. And of course, urinary incontinence is one of the important problem what a geriatric male is going to have due to prostatic enlargement and so on, which is again a geriatric problem. So since they do have urinary incontinence, they do try to walk fast or move from one place to the other place, right? Or probably a restroom very fastly, and that could be a reason for fall. The other intrinsic factors would be medical conditions, right? Inclusive of untreated pain, right? Definitely, if the patient is going to have OA knee, getting up from sitting to standing would be a problem, right? So in the process of doing, they might sustain a fall, cardiorespiratory issues, fear of falling, and previous falls. This is a very important intrinsic factor. A geriatric person might not have any specific disease except for geriatric problems, but due to some reason, if he had a fall once, what happens is he goes in for fear. Probably he will have a fear that he might fall in a similar situation, and that will restrict him from going on for such situation, and that is going to slow in due course of time, result in lot of cyclic changes and reduced quality of life. Social isolation. Lot of studies says that social isolation, when they don't socialize, when they don't mingle with people, when they are isolated, when they are confined in a single area, that can result in a fall, because their level of thinking, their level of activity gets reduced. Medications, right? Many individuals, many aged individuals do have getting treatment for many issues in terms of diabetes, hypertension. Apart from that, some other issues like say insomnia and so on. So when there is going to be medications given, if at all any specific disease also, some medications can put them drowsy, then can put them very lethargic, and that could be one of the reason for a fall. And of course, vitamin D deficiency, which is an age-related problem, which is found to be more in females than that of males. So the extrinsic factors, right? So looking at the intrinsic factor alone is not going to be solving the problem. Extrinsic factors need to be considered. cluttered environment, the environment where they live, right? In a home environment or wherever they are, right? So the environment, if it is cluttered, right, where you don't have sufficient space, sufficient environment to work, that can bring about a fall. Low lighting, which can be aggravated with the decreased vision, so many a times. Unsafe footwear. If the footwear is going to be ill-fitting or if it is not of suitable size, definitely that is going to bring about a fall. Uneven surface or uneven steps, slippery surfaces, and of course, home hazards such as rugs and mats, right? If it is not properly positioned, definitely will bring about a fall. So most factors, whether it could be an intrinsic or extrinsic, are modifiable, right? We need to know which are to be modified, which are to be prevented, and which definitely need to be addressed. So whenever there is a geriatric population, we can actually predict if at all they are vulnerable for a fall, right? Based on certain history, right? If at all they have a previous fall, if at all they are associated with a visual or an auditory impairment or a urinary incontinence, definitely they are vulnerable to a fall, right? So you can predict, yes, this person might have a fall. So you should be very careful that you don't going for or you don't prevent them from fall by giving sufficient education and so on. So when you look into the types of falls, falls can be simply a slip or a trip, right? Probably they wouldn't have landed up to the ground, but still it is actually a near incident where they might fall and falls while attempting a difficult maneuver. So probably at the age of 80, getting up from sitting to standing itself is a difficult maneuver, right? So whatever. So being a therapist, we need to know what is a maneuver that's found to be very difficult and which is bringing about a fall. If it is going to be having a same pattern, definitely find out what is that maneuver all about. Syncope, seizures, or a drop attack, as I said, a sliding off from a furniture. So why do I say this as a type of fall, right? When it is going to follow a definite pattern, when it is going to have a definite pattern, I have to look into for the pattern, study the pattern and find out how to prevent, how to treat. Psychosocial manifestations of fall. So what happens when a person falls, right? So immediately after a fall, there could be lot of manifestations, right? First and foremost, anxiety. Yes, a person has fell already. He did not have much of hurt, probably not even a simple external wound, but still what happens when he's into an environment, he becomes very anxious because he has fallen down. There could be loss of consciousness, as I said, if there is going to be a TBI, and social withdrawal in due course of time. Yes, I had a fall once or twice because I walk very fast. So they don't walk fast or they don't restrict walking in a social place, and that can result in a withdrawal, restriction in ADL, post-fall syndrome. This post-fall syndrome is nothing but immediately after a fall, they would not be able to get up or they are left behind, right? So it's not because they do have some neurological issues or they do have a severe hurt, but still the fall syndrome is severe that they are not able to get up. Fallophobia, loss of independence and control, depression. Depression, as I said, when they restrict themselves, withdraw themselves from social gatherings or socialization, definitely they land up in depressions and feeling of vulnerability. The thought of having a fall again, fear of fall keeps on increasing, and sometimes that is going to restrict them from their regular routine also. So as I said, post-fall syndrome is a very important component which we need to look at, right? Where the patient, or sorry, not a patient, a geriatric person is inability to stand or walk unsupported in the absence of any neurological or an orthopedic abnormalities that would influence gait or balance, right? So you can understand that immediately after the fall, the person might not have any neurological or an orthopedic abnormality, but they are not able to stand or walk immediately, right? So that we call it as post-fall syndrome, right? So we need to really work on what is really happening, right? So this can be analyzed after 2 or 3 falls, history of 2 or 3 falls. Fallophobia. fearful anticipation of a fall. This is very threatening. So this is actually going to reduce the quality of life and mobility of a person following a fall, right? So he doesn't want to be mobile. He doesn't want to socialize. He keeps himself withdrawing slowly from one after the other because he's got a fearful or anticipation of a fall. Now coming on to the fall risk assessment, right? What is a need, why we need, and how we are going to go about. So fall risk screening is a process of estimating an individual's risk of falling and classifying the people as being either low or increased risk. So based on this low, moderate, or an increased risk, I'm going to address that population. Depending on where the individual lives, either in the community or in a residential aged care facility, they are, in a home, or whether the person is going to have a lot of comorbidities, whether there's going to be a history of fall and many other factors, that we are just going to do this fall risk assessment with a detailed subjective and an objective evaluation. Right? So you can see the reference that is given, that's going to have a very good explained information about this fall risk assessment, right? So based on the history of whether he had a fall or if at all, if he had a fall, whether it was a one fall or two or more, we can simply say whether he's in a low risk, intermediate risk, or in a high risk, right? An older individual who does not have a fall history at all, or single non-severe fall, or a no gait or balance problems, that is, he is going to be somewhere on 65 and above, right? He does not have any fall history, but sometime probably in a near past, he had a simple trip, right? And with no balance or a gait problem, I say that he's in a low risk of fall. An older adult who's got, a history of one or two falls, but with no gait or balance problem, I call it as intermediate risk of fall. And an old adult with a fall and one or more of the following characteristics. Apart from the fall, the individual also has multiple falls in the previous 12 months, history of frailty, unable to get up after the fall without the help for at least an hour, and accompanied loss of consciousness, right? In this condition, I say high risk of fall. This is simply just saying whether he is having a low risk, intermediate risk, or high risk based on the history of fall alone. Apart from that, we need to have a very good subjective objective evaluation to know how we are going to plan his management. When you look into the management, the best practice on management of falls and injury prevention include a comprehensive risk and functional assessment of an individual and the implementation of standard and individual fall prevention strategies. See, though we know that, yes, in a geriatric population, I'm going to work on strength, I'm going to work on mobility, I'm going to work on balance, yes, but still, only a good subjective and objective evaluation will help me know what are the key areas I'm going to work and how could I individualize the treatment plan for that particular person, right? So I need to have a detailed history done, right? So looking at the medical history, whether the person has got a chronic condition, right? Either an arthritis or a Parkinson's disease or a stroke or an osteoporosis, which are going to be the very common. Apart from that, whatever could be the medical history that need to be taken into account. History of falls, right? So what could be the number of falls in the last 1 year, the cause of fall, frequency, circumstance, and whether the person had any injury, medication, polypharmacy, especially sedatives and antihypertensives. What do you mean by polypharmacy? Having more than 2 or drugs in a time, right? So for probably it could be an antihypertensive, a sedative, or sometimes a drug for an Alzheimer's or a dementia, whatever it is, right? So polypharmacy, anything more than 2 or 3, we call it as polypharmacy because that need to be noted. This could have an impact on the person's alertness or the making him lethargy, and that could be a reason for the fall, right? So need to know about the medication history of the geriatric person. And of course, the vision and hearing issues, bowel and bladder to know whether there is any incontinence, cognitive status, whether there could be any memory loss, judgment issues, fear of falling. As I said, when there is one history of fall or one fall incident, that geriatric person definitely will have a fear of fall, especially initially in the same circumstance and later on in any circumstance. So you need to know whether the person has got a fear of fall. How am I going to know? There are simple questionnaires available, single question survey, fall efficacy scale, activity specific, balance confidence scale. These are simple scales which can be used for screening fear of fall, right? So out of which your fall efficacy scale is going to be widely used, right? So it has got 10 components scored for 100, and to say that whether the person is going to have fear of fall in certain activities, right? So it's a self-rated questionnaire, and anything more than 70 is going to say that that person is going to have a fear of fall. Coming on to the objective assessment, my objective, when you look into an objective assessment, it is going to be focusing more on balance and gait, right? So because as you know, balance is a very important component that's going to be declining in an aged population. The reasons could be multifold. As I said, it could be because of decreased sensation, decrease in the muscle mass, decreased vision, decreased hearing, and so on. But I need to assess the balance as of with certain outcome measures, right? See, the first one, which is going to be used as timed up and go test, right? As you know, we make a geriatric person, walk for 3 meters, ascending from a chair and coming back and sitting into the chair, right? So that's timed up and go test. It's a very important standard test used for geriatric population. And the time, if it's going to be more than 13.5 seconds, it is said that the person might have an increased risk of fall. Work balance scale, it's a single predictor for and single best predictor for falls. And again, it has got 14 components, and if the score is going to be less than 45 out of 56, then that person might have a high risk of fall. Functional reach test, right? So you have functional reach could be forward reach, backward reach, or the sideway reach. The most commonly used is the forward reach test, right? So if it is less than 6 inches, there's a significant risk of fall. 7 to 10 inches, moderate risk, and more than 10 inches, it is going to have a low risk of fall. Sit to stand test. Again, these are all simple clinical tests which can be used. Sit to stand test, you can see, you can have two types of sit to stand test, 5 times sit to stand and 30 seconds sit to stand test. 5 times sit to stand, we just simply ask elderly population to get up from a chair and sit for 5 times, right? You can see this is a normative value for age as mentioned, 60 to 69, 70 to 79, and 80 to 89. If it is going to be more than that, then we feel that the risk of fall is going to be more. And you can see on the right side, 30 seconds sit to stand. We simply ask a geriatric population to get up from sitting and stand, which can be done for 30 seconds, right? So count the number of what they do in 30 seconds. And based on that, we try to find whether it is within the normative value or it is going to be very poor. I've just given the below average, average, and the above average values. If it is just going to be less than 14, right, then it is going to be having a risk of fall. Apart from that, we have a gait assessment, dynamic gait index, or a functional gait assessment, where we make a person walk for 6 meters. If it is less than 5.5 seconds without aids, there is no risk of fall. But when it's keeping on increasing, it is always associated with a fall risk. Apart from that, we do have observatory gait pattern in order to know about the step length, base of support, arm swing, postural control, and so on. And apart from all these gait assessment and the balance assessment, we need to be very clear or simple position changes or balance maneuvers and gait components in functional assessment. You know, before any individual geriatric population sustains a fall, right? There are certain issues where they have balance problems or where they would see, where you can witness position change problems. So when you feel that there is all these position change or a balance maneuver, that is the time you really need to attend a geriatric population before you could land up in a fall, right? So these are some of the position change which we need to really look at, right? Getting up from a chair, sitting down in a chair, just sitting in with the eyes closed, turning the neck, reaching up and bending over. In all these things, if you feel the geriatric population is going to have a problem, right? And that is where you need to really address them, because these are the subtle signs which can say that, yes, the next stage would be a fall. So you can really catch them if you feel that they have subtle issues in all these activities. Apart from that, you can see in the gait, right? Whether they have problems in initiation, step height, step continuity, they would not be able to continue with their steps. Step symmetry, unequal step length, path deviation, not able to walk in a straight line, turning, right? They just can't turn, right? So probably if you feel that they have issues in all these simple activities, subtle changes, if you see, definitely you need to address, because if it is not addressed, definitely this can bring about a fall in all these activities. Coming on to the objective assessment, right? In terms of muscle strength, right? I need to focus more on lower limbs. Of course, it doesn't mean that upper limb is not a thing. And research says that lower limb muscle strength are going to be reducing more than that of the upper limb, especially flexors, extensors, knee extensors, ankle dorsiflexors as of walking is concerned. And you can make use of simple manual muscle testing or handheld dynamometer, range of motion assessment to see whether the range is completely full, especially the lower limb in terms of ankle dorsiflexion, hip extension, spinal mobility, which could impair their balance. Postural assessment in terms of kyphosis, scoliosis, or a postural sway that can affect the balance. Sensory testing, as I said, proprioception, light touch, vibration, all these things can be affected, right? Proprioception, loss of proprioception is one of the reasons why they land up and decrease balance and thereby falls also. You can make use of standardized tools, monofilament test that can be used. Apart from that, other neurological screening in terms of reflex coordination, looking in for spasticity, if at all the person or the geriatric population has got a specific condition also. And looking for the environmental and functional assessment, very important, the place where they live, the environment where they live, whether there is a loose rug, poor lighting, looking for how the stairs is very steep or so, what could be the footwear that they wear, right? Whether it's ill-fitting or properly fitting, use of assistive devices, walkers' canes, are they appropriate in terms of height, in terms of the bushes that they carry? All those things need to be looked at. Coming on to the fall risk stratification, right? After the assessment, as I said, we classify the geriatric population as low risk, moderate risk, and high risk. And as I said, looking at these risk levels, we do also have common tools that are being used, right? So the common tools are fall risk for older people in the community, FROP, and fall risk assessment tool, that is FRAT tool. So the most commonly used is the FRAT tool, where it looks, which has got two components, part 1 and part 2. Part 1 has fall risk status and part 2 is the risk factor checklist, right? So you can just go in depth of it and look at where you have the history of falls, medication, psychological, cognitive status, whatever we discussed, right? And later, after looking at all those things and scoring based on, based on the scoring that is given, we can see what could be the risk that the person has, the geriatric person has, whether it's going to be low risk if the scoring is going to be from 5 to 11, medium risk if it's going to be from 12 to 15, and high risk if it's going to be 16 to 20. And after the knowing the fall risk, we go in for specific management. So this slide shows a simple algorithm as said by the WHO, right? The world guidelines, right? An algorithm to know whether there is going to be a low risk or a medium risk or a high risk for a geriatric population in terms of fall. You can see this, the topmost box is going to show about the how a person is going to come to you in terms of a fall. So, we always advise a geriatric population to go for a regular health checkup. So when they go in for a regular health checkup, and in the regular health checkup, if they are found to have a history of fall in the last year, then they are to be screened. Or apart from that, you can see on the right side, here you have a patient where he reports to the hospital with a history of fall, right? So in that case, he has to go in for a severity of fall in terms of injury, in terms of frailty, in terms of loss of consciousness, what actually happened following a fall, right? If it is just because he has been doing a regular health checkup and based on that he was found to have a fall, then he goes in like this, right? Where you're looking for what could be the fall history and so on, right? And if the patient if the geriatric population is not going to have any fall severity in terms of all these things, check in for the gait and balance. So if there is found to have a good gait and so on, you can see the patient, the population, the geriatric person is not going to have any abnormalities in terms of gait or a balance, then he enters into the low risk. But if he is going to have a balance problem when you assess, he enters into the intermediate risk. And here you can see if the fall severity is going to be more based on all these components, he enters into the higher risk, right? So, why do you want to go in for this such risk stratification is for a low risk group, it is going to be more in terms of preventions and educations. Whereas for intermediate and high risk, we need to identify what is the risk factor that is bringing about the fall in them, and we need to go in for tailored exercise on balance or gait or whatever it is bringing their fall, right? So this is actually a simple algorithm to know, this is actually a world guidelines to know how we have to approach when you have a history of fall in the last 12 months. Now coming on to the fall prevention strategies. So fall prevention strategies can be standard or it should be individualized depending upon the individual needs, right? An effective exercise program include strength, balance training are proved to have a reduced risk of falls as per WHO guidelines, right? Any program that you took, whatever we are going to speak in the future slides, right? Any program that you see, it is going to have a component of strength and a balance. That's very vital as of your fall prevention strategies are concerned. As I said, when you look into for the intervention, these are the areas that we really target. Strength training, balance training, gait training, flexibility exercises. Flexibility is going to be very much reduced. That's the reason, especially the ankle RM is going to be very, very much reduced. And that's how they trip and fall, right? When the ankle RM, dorsiflexion is going to be reduced, the chances of tripping and falling is going to be more, right? So we always go in for flexibility exercises, and of course, functional training, and ultimately the dual task training, which is going to be the topmost one. Okay, these are the components that we really address. And here are some of the evidence-based interventions, right? I'm just going to show few evidence-based intervention. As I said, whatever might be the evidence-based protocols that we are going to see, it is going to have a component of balance training, a component of strength training, and some have a component of cognitive training also. So this actually an evidence-based intervention Otago exercise program, which was developed in New Zealand, and it was found that it can reduce falls in older persons. It consists of 17 strength and balance exercises and a walking program, which has to be done 3 times a week in home or a community setting. So 5 strengthening exercise with 12 balance exercise, and which need to be progress based on the individual strength, right? On the right side, you can see the exercise, the strength and the balance program. This Otago exercise program. And then you have Tai Chi for balance, right? So this actually Tai Chi is nothing but a slow control movements which can improve stability, coordination and mindfulness, right? So this is actually going to have very minimal stress on the muscles and joints, and it is actually ideal for all ages, and elderly population actually enjoy such exercises, which is advised for 2 to 3 times per week, and it's found to be effective. Research says that it is effective exercise for preventing falls and improving balance ability in older adults. Then comes stepping on program. This again a good evidence based program, which is associated with 31% reduction of fall risk among community dwelling people aged 70 years and older who have a history of fall. It's actually a 7-week of group program, right? Many of these evidence-based program, if you see, it's all a group program. And when there is a need, it is customized or individualized, which involves balance, strength, and environmental modification, progresses from simple home tasks to community challenges. Then you have your FAME program, which is actually fall management exercise program, which includes balance specific, individually tailored, right? So the previous 3 programs were all both individualized as well group, whereas this is actually an individually tailored program, which is going to train based on strength, endurance, flexibility, gait, and functional skills to avoid fall. It's going to have a set of exercise program also apart from that, other components. So virtual reality, I have to say this, though we have so many programs based on strength and balance, right? Virtual reality, again, this is actually going to improve balance only, but then it is upcoming program, upcoming intervention, which is found to be engaging for elderly population. See, many times when you give a set of exercises for an elderly population, they don't do it because it is very boring for them to do all through the day, right? So when you engage them with virtual reality, it is actually a very interesting program for an elderly population, because virtual reality, especially the immersion type of virtual reality, helps to immerse and interact with the virtual environment, which is going to simulate a normal environment or a real life scenario, right? So that's why it is going to be interesting, and you can, it has to be in, the intervention has to be planned for 20 to 45 minutes in for a session, 3 to 5 times a week, right? So whatever the picture on the right you're seeing is actually a virtual reality, what we followed for our geriatric population, and we also did a study on it and we published. It was found that the balance had tremendously increased in these population, and they were very much interested to do this, exercise. And whatever might be the exercise that you do, right, you need to progress. That's very important in terms of balance, right? So you need to improve their static and dynamic balance in terms of reducing the base of support, going in for a single leg in terms of support, where you try to support them initially and slowly withdraw in terms of the surface on which they are being trained, right? Where from firm surface to uneven surface in terms of vision and the complexity of the task, right? That's very important. On the right side, you can see the dosimetry, which is nothing but you always start with a warm-up exercise. That's very important. Start with a warm-up exercise, go with a static balance, then a dynamic, and then going for reactive perturbations, then go on for strength training, and finally cool down. This is very important, right? For a elderly population. And apart from that, you always need to address the environment and the education, right? So environment, as I said, the living environment of the geriatric population need to be screened, right? So you have to remove the hazards that is going to bring about a fall, right? The mats and the loose rugs in the floor that can bring about a fall. Adequate lighting is very important, right? And environmental modification, other environmental modification in terms of a grab bars in the toilets, very important. All these things need to be think. So fall prevention tips, right? You need to educate the elderly population, right? So just placing a grab bar is not very successful. You need to educate the population. Yes, whenever you are going to get up from the restroom, right? Use a grab bars. That's very important, right? Home safety things are to be considered. Railing, sometimes if you feel an elderly population at the age of 80 is comfortable walking with the rails on the sides, you can always go in for an environmental modification of fitting the rails, especially in the area where he moves around the halls and the rooms wherever he is. Medication review. If the if the elderly population is going to have a polypharmacy, more than 5 drugs, right? We revisit and re-prescribe. That's very important. What are the inevitable drugs to be taken and what could be compromised, right? Revisit to be done. And engaging in these social activities, right? To prevent isolation. That's very important. As I said, research says social isolation can increase the falls. So that's what I was saying. Medication modification, sedatives, antidepressants, antipsychotic drugs can contribute to falls by reducing mental alertness, reducing their, bringing about lethargy, right? And you need to look at that, revisit their prescription and re-prescribe. Of course, we are not going to do that. Ask him to consult a physician and find out what could be deleted and what could be added. There is a criteria called as BEAS criteria, which is nothing but a list of medications that are potentially inappropriate for the use of elderly. And some of them can increase the risk of fall, right? So if they are so, find out whether it's mandatory to be taken. So apart from that, we need to have a multidisciplinary referral also, an OT, who's going to suggest home modifications, cognitive related intervention. When you feel that cognition is reduced in an elderly population, you have to go in for a cognitive rehabilitation simultaneously. So that can be, an interprofessional approach can be dealt with, and you can bring out a good program that goes hand in hand. Vision and hearing specialist, dietitian, very important, right? So as I said, vitamin D supplements need to be taken up. That could be one of the deficiency can bring about a fall and reduction in muscle mass and so on. So you have to go in for vitamin D intake, natural food as well as supplements. And if the population is going to have some other specific conditions, definitely a neurologist has to come into the picture, right? And finally, just giving an example, what could be the way that we just go about, right? So here is an individual, a geriatric population at the age of 75 with a fall history of 2 in the past 6 months, 1 due to tripping over a rug and other due to a ill-fitting footwear, right? And when you're looking for the subjective history in terms of medications, there were 5 medications, including antihypertensives. And the fear of falling questioner says, yes, there is a definite fear of falling for that geriatric person. With the objective examination, it was found that time tap and go test showed 15.2 seconds. Work balance scale showed that it was 42, conveying that there is a definite history of fall, right? MMT showed that bilateral hip abductors had only 3+ for 5, and gait showed slow, wide waist, decreased arm swing, and so on. Right? The FRAT scale, FRAT is nothing but fall related assessment tool as what we said, right? It showed that the score was 13 for 20, right? So that also showed that there was a high risk for fall. So the overall interpretation said that there is a moderate fall risk due to decreased strength, impaired balance, and polypharmacy. The plan was based on the strength interpretation. The plan was strengthening exercise for 3 times in a week, balance retraining, home safety, education, and correcting the footwear, and of course to refer for an OT for the home assessment. So this was the plan. So this is how we go in with the subjective history, go on with the objective test in terms of various outcome measures, and finally interpret what could be the fall risk as of that particular individual and plan according to the need, which is going to be customized and individualized. And if required, go on with the professional as well required. So that's about the fall risk. So thanks for the patient listening. If you have any questions, it's open.
Thank you so much, ma'am. Ma'am, I have one question.
Yes, ma'am.
How does the risk of future fall change, ma'am, if a patient had a fall or related injury in past year?
How much change you can see?
Yes, ma'am.
Depends upon the history, ma'am. Probably if it is just going to be a visual related or an environmental related, correcting them, you can have a very good change in the fall risk. But if it is going to be associated with a specific condition, or if it is going to be associated with sarcopenia, right? Many a times sarcopenia is not going to be completely reversible in case of a geriatric population. Definitely, you can go in for strengthening, but you cannot completely revert. Definitely. So it is actually based on the cause of the fall. Certain causes are reversible, certain are not.
Okay, ma'am. Thank you. Then, what are the key factors to be considered, ma'am, when assessing fall severity in older adults?
Key factors in the sense, you need to assess the cause for the fall. That is very important. As I said, initially I was speaking about the intrinsic and extrinsic. So you need to assess the intrinsic and extrinsic. That's very important. Apart from that, as I said, definitely age-related changes are inevitable. So looking for their strength, mobility, and balance. These are the important things that we need to look in. Apart from that, the other factors need to be looked in terms of environment and so on. So if you are going to address the factors, whatever you feel is lacking, definitely you can have a very good improvement. Definitely.
Thank you, ma'am. Thank you so much for your insightful presentation, ma'am.
Thank you, ma'am. Thanks for the opportunity.
Okay, ma'am. Ma'am, please wait a minute, ma'am.
Yes,
Now
ma'am?
let's move on to the
Yeah.
uh, now let's move on to the vote of thanks. On behalf of everyone present, take this opportunity to extend my sincere and heartfelt thanks to Dr. Rajeshwari ma'am for her insightful and enlightening presentation. A depth of knowledge, clarity of thought, and articulate delivery have greatly enriched our understanding of the subject. We are truly grateful for the time, effort, and expertise she has generously shared with us. Her dedication to advancing knowledge and guiding others is commendable and deeply appreciated. With respect and admiration, I offer this vote of thanks to Dr. Rajeshwari ma'am, acknowledging her valuable contribution and wishing her continued success in all her future endeavors. Thank you so much to our IEP team members and participants for your valuable time. Once again, thank you so much, ma'am.
Thank you, ma'am. Thanks for the opportunity.
Thank you so much, ma'am, for today's insightful session. Thank you, Team Tamil Nadu, for conducting this series of webinar. Today was day 7 of the webinar on the topic Understanding Falls in Elderly. And tomorrow we would be having a webinar on the topic The Evolving Role of Physiotherapy in Healthy Aging. a comprehensive geriatric care. The resource person for tomorrow's webinar would be Dr. K. Kamachi ma'am, and it would be under the banner of IAPWC Tamil Nadu team. So there was this series of webinar that was on. Today was day 7, and we are very much happy to tell you that we have been successfully conducting this series of webinar on occasion of World Physiotherapy Day. Thank you all the participants and all those who have joined us online, and all those who will be viewing our recording sessions later on. If you have any queries, you may post on to the chat box. We may let it know and get it cleared from our moderators and the resource person. Thank you once again for everyone for joining us for today's webinar. Thank you.
Thank you.